So why this topic was selected, if you see, I normally believe basics are the advanced content. If only a person knows the basics, then he is considered to be a person with in-depth knowledge. Um, Unfortunately, in orthopedic assessment, if you see, you have an assessment pattern where you go about in analyzing what is the impairment. When I say impairment, I mean about the anatomical structure, maybe a dysfunction or derangement, whatever it is, but you are going to find out the anatomical structure in the orthopedic assessment. But in neurological, the clinical scenario, or in the colleges, or in the universities, wherever you perform the assessment, you know what is that condition. The assessment is tailor-made for that condition. Am I right or not? I have seen many times people asking me, sir, I don't know stroke assessment, I don't know spinal cord assessment. So how do they know that it's a stroke patient? How do they know that it is a spinal cord injury patient? Because here the medical diagnosis and the physical diagnosis are they are based upon the condition. It is a condition assessment. It is not physical diagnosis or physical diagnosis from physical therapist. It is mostly condition oriented. Whereas if you see in the orthopedic assessment, they have come to an extent where the assessment is not condition oriented. If I say periarthritis assessment, I may not be sounding correct. In periarthritis, you are going to identify which is the particular periarticular structure that is inflamed. So they have gone so deep into the impairment level, and the physical diagnosis in orthopedic assessment is possible these days, but the physical diagnosis as far as the neurological conditions are concerned are mostly a formality. I think people in this group would agree with me, because what is meant by assessment? Assessment is identifying what is the ailment, identifying what are the problem list, and what are the hints for the future intervention. But when it comes to neurological condition, when a patient walks into you, you know that he is a Parkinson patient. Most of the time, he is being declared that he is Parkinsonism. And your treatments are also predetermined. And here, the assessment becomes a mere formality. But for a first visit practitioner, if a physiotherapist wants to claim that he's a first visit practitioner, he should know the differential diagnosis. He should know before anybody diagnose a condition, if the patient walks into you, without referring the patient to the neurologist or without referring the patient to elsewhere, you should know how to assess the patient. That is the main concept of differential diagnosis. I definitely know that it is not going to come in 1 or 2 days of patient assessment and clinical practice. It is going to take a lot of time for you. But the basic knowledge what you want to attain is very important. If you don't have a strong basics, you will progress with the pseudo basics. That is a pseudo knowledge what you have got, the knowledge which is not correct, which is not physiological, which is not scientific. With that knowledge, you will progress, and it will affect your clinical practice. And thereafter, whatever experience you have gained out of that particular clinical experience is going to be not that significant, because you are practicing on myths, not on science and physiology. So basics, my dear friends, anatomy and physiology of any system is very important, and that is the only thing that is called as advanced when it comes to uh, uh, biology as such.